All right. I appreciate the opportunity to speak to this fine institute. I'm a practicing oncologist, and I'm also president of the Community Oncology Alliance, also known as COA. So I have to figure out the right button here. Well, I only got two more to try here. There we go. So I'm talking about the shift in the site of care, and I want to start off by talking about the challenges to community oncology. If we better understand those, then we may be able to intervene and stem the shifting in the site of care. So the practice challenges could be looked at in four broad categories. There's increasing costs, declining reimbursement, increasing administrative burden, and increased uncertainty. Okay, so I'm going to deconstruct these categories and talk about them in a little bit more detail. Starting off with increasing costs, we have the higher cost of doing business, even though inflation's been tamed over the past 10 years. Even 2 to 3% yearly rise of inflation leads to about a 25 to 30% increase in the cost of doing business. In addition, practices have had to make substantial investments in EMRs. And as you know, they're not just boxes that sit on desks, but they're complex IT systems that have to be maintained, and there's got to be regular update of hardware, and there's yearly fees for maintenance of the software that can cost tens, if not hundreds of thousands of dollars. So it's a very expensive endeavor. In addition, there's increasing drug prices, and this hits the cash flow of a practice very hard because we're having to, I guess, have more dollars tied up in inventory sitting on our shelves than we did in years past. Our practice of 22 physicians in about 5 or 6 years ago, our inventory used to be about $500,000. Now we have $1.2 million worth of inventory, and we keep our inventory very lean and just in time. So again, that ties up cash that can't be used for other operations. Okay. Okay, so the next challenge has been declining reimbursement ever since the Medicare Modernization Act of 2003. There's been a steady decline in reimbursement for our administrative services, as well as the fees that we get for providing chemotherapy to the cancer patients. And over the 10 years, decline in administrative fees have been about 1/3 of what they were back in 2003. And as far as the chemotherapy, yes. Okay, yeah. And for the chemotherapy revenues, there's been a 2/3 decline in the excess in terms of our fees that we use to provide those drugs. So hopefully I got the right button here. So community oncology was really hit hard with sequestration that went into effect last year. Not only did we take a 2% cut to our administrative services and our E&M services like all physicians, but sequestration also hit our drug reimbursement. So the 2% not only applied to our 6% margin that we get paid by Medicare, but it also applied to that 100%, which is really what we pay back to the distributors, who in turn pay the manufacturers. So in essence, we're paying the sequestration charges for pharma, if you will. And so ASP went from the traditional ASP plus 6 that we get paid by Medicare to ASP plus 4.3. And in 2014, we had further cuts to our administrative services by 2%. And for those practices that paid or had radiology services, they also received further cuts. So what this has resulted in is that you see the yellow line is the total practice revenues, and the blue is the operating costs. And as these lines converge, it's going to put more and more pressures on the practices to seek cover from the hospitals. And that's reflected in the next slide, or it'll be a following slide. But in addition, there's increasing administrative burdens. We have the work of providing information to specialty pharmacies for which we're not reimbursed. There's also the usual pre-certification of procedures, which seems to be becoming more and more burdensome. In our practice, there's the, I guess, trend towards using guidelines. In our practice, we have to use 5 different guidelines for 5 different payers. So keeping all those straight for the physicians and administrative staff is quite a challenge. Finally, there's the CMS quality programs. Prior to 2013, if a practice didn't participate in the program, then there was no penalty. But starting last year, if they didn't participate, then there's penalties of 1.5% to 2%. And these particular programs are quite complex. They're the administrative equivalent of trying to find a needle in a haystack and having to do it day after day. Finally, there's the increased uncertainty of how the Affordable Care Act is going to play out. There's a concern about when the next shoe is going to drop in terms of government reimbursement. And then, of course, there's the ups and downs of the general economy. So I'm not trying to sell you cell phone service. This is what's happening to community oncology. We have the blue dots representing practices that have merged or have aligned with the hospitals. The pink dots represent practices that have merged with other practices. The red represents clinics that have closed, and green represents practices that are sending patients elsewhere for treatment, and then finally the yellow represents those practices that are struggling financially. So, we're going to concentrate obviously on the trend towards physicians to align with the hospitals, and clearly that's the most common trend out there, and the reasons are quite appealing, especially to physicians and the hospitals. And for physicians, there's stabilization of the compensation. There's less worry about what's going to happen to payer reimbursement. There's less administrative burdens. And, of course, physicians can spend more time on patient care, which is, of course, what we were trained for. The hospitals, of course, get a new service line. They get an elimination of competitors, particularly in those markets that also the physicians provide radiation and radiology services. There's the alignment of key specialists to develop a vertically integrated network that can be leveraged for payer contracting, et cetera. And then finally, we got the boogeyman of 340B pricing. In order for a hospital to participate in that program, they have to have contracted physicians. So it used to be said 80% of the oncology patients receive their care in private practice. Now that number's down to about 50 to 60%. And this puts some numbers behind our cell phone map. And the biggest number is that 469 practices have merged with the hospitals, and that was of 2013. So, the question is, what does this mean in terms of quality and value? As far as the quality component, there's no studies that I'm aware of in which care in the private practice has been compared to that in the hospital setting. But there have been at least 4 major studies that have looked at what has happened when there's a shift in the site of care and what that means in terms of costs. So we'll take a look at the first 2 studies that deal with Medicare beneficiaries. There's the 2011 Milliman Study that looked at data from 2006 to 9. And the cost of care in a hospital outpatient setting costs Medicare $6,500 more per year per beneficiary. And the patient's out-of-pocket cost was $650 per year for 14, and what that translated to is a 14% cost differential between the 2 sites of service. The Moran study followed up in 2013 where the Milliman left off, And there they found there was a 33% higher cost of care for the hospital outpatient department versus the private practice. There was higher drug spend and more cycles of chemotherapy given in the hospital setting. And you can see there's a difference between the two studies, and I think that reflects that from the 2011 study to the 2013 study, there's been a progressive divergence in terms of reimbursement for the hospitals versus the private practices. Now, over the past 10 years, the hospitals have steadily gotten a pay increase in terms of their chemotherapy administrative services, where the practices have had a steady decline. And that trend continued through the 2011 data. So the cost of care also is affecting what the commercial payers have to spend for drugs. The Avalier study was the first to look at this particular issue. And they looked at all cancers, and they found a wide variation in terms of the cost differential, but they're all higher in the outpatient setting. And the differential depended on what cancer was being treated and the length that the patient was under treatment. And the patients that were treated for a year had a very marked difference in terms of the cost differential. Not only was the cost differential higher for medical oncology services, but it was also higher for radiation services. The next study was the 2013 Milliman Genentech study that looked at the big three, breast, lung, and colon, and looked at adjuvant and metastatic episodes of care, and found that in the hospital setting, the cost of care was 28 to 52% higher on average. So clearly, these four studies are all congruent in that, the cost of care is clearly higher in the hospital outpatient department. And, what that means to the patient was reported in the IMS Global Trends Report, and the cost was $134 higher for the patient per session of chemotherapy if they received their treatment in a hospital outpatient setting. And of course, that's not their only cost. That's just a higher cost from what they would have been charged if they were in the physician's office. So just looking at this from the different stakeholder perspectives, I've already talked about the hospital and physician stakeholders. I want to just touch upon the payers and patients. For the payers, they recognize that oncology care was one of the key factors driving their expenditures. They want standardization of care in the lowest cost setting. Obviously, they're very concerned about this shift in the side of care because it's going to increase their costs. And finally, many of these payers have limited leverage with the hospitals because in many communities there's only one hospital, and the payer needs the whole basket of services that the hospital offers. And so if they negotiate hard on the oncology service line, then they'll be charged higher fees somewhere else in the basket of goods. For the patients, obviously they're concerned about the higher out-of-pocket costs. They want high-quality care, and they want compassionate care. And finally, they want care close to home. To paraphrase our next speaker, this is logistical toxicity, given the fact that 288 clinics have closed in as of 2013. One of the COA team members is a breast cancer survivor, and she repeatedly tells us that, when you're sick and you have to travel 30 miles to see the doctor, then it feels like 300 miles. So clearly, this is a major issue to the patients. So which of these is worth saving? I hope you don't pick the ugly car. Clearly, I believe community oncology is worth saving. It provides low-cost care close to the patient's home, which meets at least two of the stakeholder needs. We at the Community Oncology Alliance, recognize the need for oncology payment reform and have been working hard on the oncology medical home model and, associating that with a shared savings payment reform. However, trying to get that through Congress or is going to take an act of Congress, literally. So it's going to be probably another 3 or 4 years. And frankly, many oncology practices are struggling financially and can't wait. So there are several initiatives on Capitol Hill that the Community Oncology Alliance supports. There's House Bill 1416, which is a bill to remove the sequestration cuts to Medicare Part B drugs. There's House Bill 800, which takes out the prompt pay discount from the calculation of ASP, or the average sales price. Briefly, the prompt pay is calculated into the ASP. ASP is the price that that is charged to the distributors. It's not to the oncologists. So if the distributors pay their bills quickly, then they get a discount that's calculated into the ASP and artificially lowers the reimbursement to the medical oncologists. And then finally, there's House Bill 2869, which is a bill that's seeking to have parity in terms of payment for administrative services for the hospital versus the physician offices. So, clearly this is a ripe area for helping control costs and helping relieve some of the financial burden on the patients, because as I've shown, there's a significantly higher cost of care to the payers and patients when care is received in the hospital outpatient setting. And I think for a very small investment, community oncology can be preserved and help, again, provide expert care close to the patient's home. So thank you for your attention.
Thank you, Bruce. Our next speaker is Yusuf Safar, who will speak on the increasing toxicity of the financial burden on patients.